Thank you, Jamie. All right, so good afternoon, everyone. Our didactic topic today is a comparison of stimulants for ADHD. A couple of these questions had come up in the not so far back past during the discussion, so we thought we would take a little time during the didactics to take a look at comparing between the different stimulants that we can use for ADHD. And for Melvin, this is a teaser for the Special Pops ADHD lecture you guys will be getting later. Full disclosure, we're going to talk about stimulants. We're really going to look at them in a broad class format, breaking them into subclasses. So the categories of methylphenidate and mixed amphetamine salts. And the comparison that we're going to do is mainly focused on kids. So we'll talk about stimulants being first line for children and adolescents. So that really is going to be where most of the literature came from. So that'll be where our focus is. Not that we can't use them in adults, but just for the sake of time, I just focused on this patient population. Objectives today are threefold. We're going to compare and describe the pharmacology. So how do the stimulants work between those two classes? What are the most common side effects? There's quite a few side effects that come with the class, but we do see some slight tolerability differences between the two. And then we'll look generally at some efficacy data. So how well do they work and does one have an advantage over the other? To start with though, why are we talking about the stimulants? Stimulants actually are one of the few psychotropic medication classes that have a significant amount of literature evidence to support their use. The American Academy of Pediatrics in their ADHD treatment recommendations have stimulants as a grade A recommendation. So grade A meaning that there's the strongest amount of evidence support for this particular class of medications. So they do recommend it for elementary and middle school age students as well as for adolescents, being used in combination with either psychotherapy or parent training in behavior management. So this is gold standard. This is what we use as really a go-to for individuals with ADHD. There's also a grade B recommendation that it could be used in preschool age students, so 4 or 5, for the methylphenidate preparation only. So some of the methylphenidate products have done clinical trials in this younger patient population. There are a lot of competing thoughts on treating individuals who are 4 or 5 with pharmacotherapy for ADHD. So that is a little bit up for discussion. The level of evidence is B, so not quite as strong as for our elementary, middle school, and adolescent patients, but so slightly less, but that's also because there's less evidence in this patient population, and we don't understand it quite as well. 4 and 5-year-olds do tend to be busy and active, and being able to identify clearly and track some of those changes might be a little more complicated in that patient population. Plus the risk of some of the side effects with them makes it less desirable for us to use this as robustly in our 4 and 5-year-olds. So first line, go-to gold standard for ADHD treatment. So with that being said, knowing that we use this pretty robustly, what are our options? There continue to be new developments in formulations of stimulants that are being approved by the FDA. As I mentioned, we have 2 main classes of stimulants. I'm breaking them into the methylphenidate class and our amphetamine salts category. The reason I'm doing that is they do work slightly differently, and that's going to be the easiest way for us to compare. So our methylphenidate category is going to include our methylphenidate products as well as the dexmethylphenidate products. So one of the specific isomers. So with our chemical compounds, we often have 2 versions of a chemical. This is kind of just isolating the one version. Sometimes it's like Celexa and Lexapro. Lexapro is that isolated version of Celexa. Celexa has both of them in there. So same thing, methylphenidate has both, the dexmethylphenidate just has the one. They do this sometimes because they see increased activity with one form versus the other, and sometimes they can change the side effects. Although in this case, it didn't do it really to a clinically significant amount. We see similar things with the amphetamine class. So our mixed amphetamine salts, these are a couple different salt forms of amphetamine as well as dextroamphetamine. Then we have some that are just the dextroamphetamine. And then there was a formulation that was created, the List dexamphetamine. So this was a dextroamphetamine compound that they added another chemical to make it a prodrug. So they were hoping that this makes it less likely to be misused because it takes longer to work. You got to break off that little piece so that you actually get the stimulant to work. But it is an amphetamine, so it falls within that category. So those are the two main ones that we're going to think about. The other piece I wanted to make sure that I mentioned, and I added some slides at the end that I'll show you that are just for information, is that we have quite a bit of variability in how long some of these preparations last. So of all of our options that we have, there are tons of options within each class. And the way that they did that is the manufacturers have made different types of products. So some are short acting. That would be like a traditional tablet or capsule. It dissolves right away. We can see an onset of effect within a half an hour to an hour, but it doesn't last quite as long. So the actions tend to wear off within 4 to 6 hours. Sometimes we use this as a booster dose in the afternoon. Sometimes this is used as a trial when an individual is just starting stimulant therapy, just to see if it works and if the patient can tolerate it, because it's not going to stick around for a long period of time. It may require a couple doses a day to last a patient throughout the entire day. We also have intermediate acting products. So those that somehow are formulated to last a little bit longer. These usually are in the form of you take one tablet or capsule. Sometimes they have the little beads in them, and some of them release right away. So you get your first dose like a short acting, and then others release slowly over time. And that allows it to last a little bit longer than the short acting does. So onset, we see similar because there is some short acting in there, half an hour to an hour. And then it'll last about 6 to 8 hours. So maybe we need to dose this a couple times a day, but some kids can get away with just once a day. Because that wasn't enough for everyone, they've further formulated a bunch of compounds. So we have some really long acting, more extended release. And these tend to be products that have more specifics. So maybe they have different size drug molecules that dissolve at different rates. We have the Concerta tablet actually has laser drilled holes. The tablet itself won't dissolve. There's an outer coating that releases the first dose. And then as the liquid from your belly gets into that laser drilled hole, it actually inflates what looks like a sponge, and that pushes the drug out so it's able to deliver medication throughout the day. We have patches. We have a whole bunch of formulations that can deliver medication for more than 12 hours consistently for patients. So then they only need to take one thing a day. So these are some of the options that are there. These would be tailored to what a patient needs. How long do they need symptom control? What type of side effects are they having? And those types of formulations hold true for both. We only have a patch for the methylphenidate class, but if we need something that lasts longer, we do have some longer acting products in the amphetamine class as well. So that is one way that they've increased our options in the stimulant class. Now, why would we want to pick between them? So knowing that we've got tons of options between these two classes, what would be the difference? They both work in similar ways. Our two main neurotransmitters they're going to work on are dopamine and norepinephrine. Our methylphenidates are going to block the reuptake of dopamine and norepinephrine. So you have your nerve, it has a signal, it releases dopamine and norepinephrine to send a signal out to the next neuron. In some cases with patients with ADHD, that signal either may not be really efficient, it's not being delivered in the same way. And if we're able to keep the norepinephrine and dopamine in that space to deliver a more potent signal, sometimes that can assist with symptoms. So by blocking the reuptake, by keeping that chemical able to push the signal through to the next neurons, the methylphenidate can help with the symptoms of ADHD. This was just a depiction that I did. It only includes dopamine, but norepinephrine would be the same thing. It's going to keep it in that synapse. The amphetamines do something similar. They also are going to block the reuptake, but in each of the neurons, so the neuron that's sending the signal, it has the dopamine and norepinephrine in synaptic vesicles. So it keeps them there in storage until the signal says it's time to release. It also keeps them out of that little holding cell, that little synaptic vesicle, so they can be released a little bit more consistently. So we see maybe even a different mechanism to increase the amount of dopamine and norepinephrine in the synapse. So ultimate goal is increasing the amount of dopamine and norepinephrine, but the amphetamine class and the methylphenidate class go about it just slightly differently. So knowing that they go about it differently, does that change the side effects that we see? Overall, not very much. I'll show you the class side effects for stimulants in just a minute, but this was looking at a couple different drug monographs, so prescribing information for methylphenidate products and some of the mixed amphetamine salt products. I just drew the line at those that were reported at more than 10%. So more than 10% of the patients exposed to these in the clinical trials reported these side effects. It was just an arbitrary number, but it gave me a list that was more manageable than doing something else. So for methylphenidate, we see decreased appetite, headache, insomnia, irritability, nausea, and dry mouth. Of those, the decreased appetite and the insomnia can stick around, where patients may not really feel much like eating. So sometimes it's recommended to make sure that they get a good breakfast in as they're taking or before they take their product in the morning. With the insomnia, so those formulations, trying to find one that perhaps wears off a little bit earlier could be helpful to adjust and treat that adverse effect that may not go away. For the mixed amphetamine salts, abdominal pain, again, that decreased appetite, headache, insomnia. We also see some systolic hypertension. So this is dose related and it can be transient. So you could see some elevation in the blood pressure when a child first starts one of the mixed amphetamine products, and then it could normalize. And that may be the body getting used to having that extra dopamine and norepinephrine out and available. Over time, though, we can see for both classes an increase in blood pressure and heart rate. So we do want to watch that, but that finding was a little bit different from what we saw with methylphenidate. So not a huge difference in tolerability between the two. They generally are well tolerated in most of the patients, starting at a low dose and moving up. Previously, it was recommended to start with an immediate release product, but that's not required anymore. We can start with lower dose of the extended release and be able to titrate from there. The class adverse effects to think about, we really see this across the board with both of the classes. So this doesn't tend to distinguish them. There's an individual difference between patients in what they are or aren't able to tolerate. So recognizing we have to keep this in mind and monitor patients, but they may just respond better to one or tolerate one class better than the other. So we really could try either one. Couple other adverse effects I just wanted to point out here. The decreased growth velocity, we have seen that reported in both classes of stimulants, and tics. So there is some discussion of, does it cause tics versus just make them worse? There are quite a few children that may develop tics temporarily, and this may make them much more pronounced. We see that with both classes of medications, and there doesn't seem to be an advantage of one over the other. Again, very individual. One may make individuals have much more pronounced tics, and the other may not do that at all. So that would be a little bit of a trial and error situation. So we can't really differentiate too much. They work a little bit differently. They seem to be tolerated just about the same. So how about their efficacy? How do they work? So I picked one clinical trial and then a meta-analysis to look at the results. There are a ton of trials available for the stimulants, but I just thought this would help us take a peek at it, but stay within our time frame. So this trial was an 8-week trial in adolescents, 13 to 17, who had been diagnosed with attention deficit hyperactivity disorder. So they split them into 3 different groups. So they either got the lisdexamfetamine, and they could flexibly dose it. They got the Concerta, which again could be flexibly dosed, or they got the placebo. They also did a trial where they only looked at the highest dose of the lisdexamfetamine, so 70 milligrams, and the highest dose of the Concerta, so 72 milligrams, and placebo, because they wanted to see, is there a difference if we flexibly dose it on how kids could tolerate it? And then if we use the maximum amount, is there a difference between them? The outcome that they used was the ADHD rating scale. And in looking at the changes, both active groups, the lisdexamfetamine as well as the methylphenidate, both of them had significant reductions compared to baseline, and they both were different from placebo. The placebo group did get a response, but not nearly as significant a response as the other two. There was no difference between the two. So numerically, it looks like there was a slight difference, but statistically, there wasn't a difference between the two. When they looked at the highest dose, they again saw a difference between both active compounds compared to placebo, and there was not a difference between the two. Yes, numerically, it looks like there's a slight advantage for the lisdexamfetamine, but statistically, there wasn't a difference between the two. So it looks like both have robust responses, significantly more so than what we see with placebo, but we weren't really able to differentiate between them. So recognizing that, I wanted to take a look at a meta-analysis. So I selected this one just because it had a little bit more of a balanced representation compared to one of the other meta-analysis that I'll mention in just a moment. So this was a review that was done. It included 29 different trials of stimulant medications in pediatric and adolescent populations. They also included some non-stimulants. So they included bupropion, atomoxetine, as well as some of the tricyclic antidepressants. This is just the data for the stimulants. What they found, so this is they did a standard mean difference in the effect size. So they looked at what was the difference between the active group compared to the placebo group and divided it by the amount of variability to try to estimate how effective is this medication. As you can see, they all, 0 would be there's no effect whatsoever. They all were significantly more effective than placebo, and they all fell right around the same range. So it didn't matter if it was methylphenidate or if it was one of the amphetamines. We seem to see similar efficacy between the two groups. So it looked like they were pretty effective. They also did an analysis looking at the types of studies. And what they found was there was a big difference based on the way that they set up the trial. If it was a crossover trial, so they started on one medicine and switched to a different one, versus if they just took their whatever they were assigned consistently. They saw a difference based on their outcome. Did they look at the change in the rating score, or did they just look at the what the score was overall at the end? Who did the rating also made a difference. So overall, stimulants were much more effective. They couldn't tell the difference between the two, but there were some logistical differences. Now, I point that out because the study we just looked at, as well as another meta-analysis that was done, have suggested that maybe the amphetamines have an efficacy advantage. So maybe they're more effective than the methylphenidate group. Because there's a lot of the variability between the trials that makes a difference. Is it a crossover trial versus a parallel trial? Who's doing the evaluation and what are those outcomes? And the fact that methylphenidate tends to have way more trials than the amphetamines seems to put that at a disadvantage. So there's not a clear consensus that one has the advantage over the other. It is something that's very patient specific that we should keep in mind. They don't work exactly the same, so they might be tolerated a little bit different, but they're both much more likely than other treatments for ADHD to be effective. And we really got to look at what would be the best fit for each of the patients because we don't have a clear winner. We absolutely have to start with this at this time. So with that, I will stop my share.